Hi, I'm Rachel Good. I'm one of the developmental behavioral pediatricians at Vanderbilt University Medical Center, and I'm here today to discuss developmental milestones in opioid-exposed children. So first, we're going to talk about what typical development looks like, starting with infants. And just remember that development is basically watching the brain myelinate, so it's really cool. But it can happen in different time frames for different children. From birth to 4 weeks, these babies may sleep a lot and they may have their days and their nights backwards, but they should become more alert throughout the day. They should be able to focus more on faces and close objects and open their hands more frequently and begin to smile. But by 4 to 8 weeks, that smile should become a social smile. They should also have their hands closer to midline, maybe even into the mouth. They should alert to a parent voice or caregiver's voice, and you might have some emerging cooing sounds. By 3 to 4 months, a child should be able to hold their head upright when placed in an upright position. They may be rolling front to back, and they should be reaching for items that are close to them. Hands are probably in the mouth, and they should be cooing using vowel sounds now instead of just cute little grunts and squeals. They may also laugh out loud. By the time a child is 6 to 8 months old, I would expect for them to sit without support, to be able to roll both ways, and maybe even trying to crawl. They should be able to transfer objects from hand to hand and have an immature raking grasp with their fingers when they're picking up something like a large cracker. If a baby is breastfed, they should be able to hold the breast, and if they're bottle fed, they should be able to hold their bottle. The baby should babble, so making consonant sounds with the vowel sounds like ma, 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 da, 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 da. And they should smile when a mirror is placed in front of them. By 9 to 12 months, the child should turn when their name is called and engage in social games like peekaboo or pat a cake. They should demonstrate separation anxiety from their caregiver, and that separation anxiety should resolve when the caregiver returns. A child should say mama and dada specifically by now and understand what no means. They should be able to bring 2 items together, one in each hand, and bang it. And they may be able to crawl or even cruise around furniture. By 12 to 15 months old, this baby is now a toddler, and they should be cruising around furniture or walking unassisted. They should have a purposeful release with their hand grasp and a pincer grasp when picking up small items like Cheerios. They should also be able to use a spoon, although there should be some spilling, or could be some spilling. And they should be able to hold a crayon to make a mark. I would hope by 12 months old to see a mama, a dada, and 1 other word, and by 15 months old to have 3 words. By 15 months old, I would expect a child to know 1 body part, for example, where's your nose, and point to the nose. I would also expect the child to use a finger point for need and have some show and tell behaviors like showing you a toy that is interesting to them. By 18 months, the child should point to an item not only because they need it, but also just because it's cool and interesting and they want to show you. They should look for reassurance if they're in a new environment from their caregivers. These children should be able to give affection spontaneously and have emerging pretend play skills that are reciprocal in nature. They should be able to point to 3 body parts and have around 10 to 25 words that they use consistently and functionally. They should also follow a single command without a gesture. For fine motor skills, they should be able to stack blocks, copy a vertical stroke, and maybe start to copy a horizontal stroke. These children should be walking independently by now and may have a cute little stiff run and may creep or crawl up and down steps. By 18 to 24 months, this child is well into toddlerhood. They should be able to run well, go up and down stairs with the rail held, and jump with their feet off the ground by 2. They should be able to help remove some clothes that don't have buttons, for example, pants or socks and shoes. They may have a preferred hand preference, and they should be able to hold the crayon in a fairly typical manner while they're scribbling. The child should have greater than 50 words and be able to put those words into 2-word phrases. They should be able to sit to listen to a story and demonstrate parallel play with peers. Pretend play should be established, and it should be reciprocal with other children as well as family members. So now that we've talked about typical development, let's talk about what may be atypical in children that have had opioid exposures. Babies that have had opioid exposures are often irritable. They are usually sensitive to light and sounds. and they may have poor feeding skills. They may have increased tone or have an exaggerated startle. I would encourage your parents and your patients to swaddle these babies and to keep the rooms dim and quiet. Remember that these children have an increased rate of maltreatment just due to their irritability. So encourage your parents that it's okay to put the baby down and walk away for a minute if they need to collect themselves. These children, as they get older, have increased risk of sensory challenges, such as sensory processing disorder. They also have an increased risk of behavioral challenges and emotional differences. As the child enters school age, they can have learning disorders, attention disorders, and other school problems that should be monitored for. And many of these children have language delays or language disorders into preschool and even into school age. So as a developmental pediatrician, when would I worry about a child with opioid exposures? I would worry if they are not making good eye contact by 12 months old, or if they're not responding when their name is called by 15 months old. I would also be concerned if they have no interest in peers or lack parallel play skills and pretend play skills by 2. Language-wise, I would worry if a child doesn't have functional language by 15 months old and is not putting 2 words into phrases by 24 months old. I would also worry if the child's language is not social in manner, or if the child has repetitive or stereotypical mannerisms such as arm flapping, hand posturing, body spinning, or repetitive play skills. I might worry about sensory differences if the child is sensitive to lights, to noises, or to certain textures on their body or in their mouths. And I would also be concerned if a child is not walking by 18 months or not mobile in some fashion or form by 12 months. So now that we've talked about typical development and what may be atypical in children with opioid exposures, let's talk about your next steps. So first of all, I would do a developmental assessment in the office that includes a standardized screen. That may be the PEDS or the ASQ or really any other standardized screen. And I would also encourage you to do the MCHAT looking for autism. I would then refer this child to early intervention services if you haven't already done that. Remember, children with a diagnosis of NAS or NOWS or NOWS automatically qualify for services or for the very least an evaluation. If the child doesn't have that diagnosis and just has been opioid exposed, if they have delays of at least 25% in 2 domains or 40% in 1 domain, they will qualify for early intervention services as well. If the child doesn't qualify for early intervention services, but you still have concerns, it's fine to send them to a center-based provider like a speech therapist, physical therapist, or occupational therapist. You can also refer the child to a developmental specialist like me. Sometimes it would be at a developmental office or even a NICU follow-up clinic. And then lastly, I would encourage you to follow up with these families frequently. Any parent that has a concern about their child is, of course, anxious and worried. And in these children, they may need a little bit more support than your typical child. So we've talked about typical development, atypical development in children with opioid exposures, and your next steps. So let's just summarize everything. Remember, typical development can vary with the child, but I would be worried if you're not seeing milestones obtained within a 2 to 3 month window of typical. Remember to look for red flags that include stereotypical mannerisms, sensory challenges, poor response to name, poor eye contact, atypical play or differences in how a child interacts with other children, delayed language, and delayed motor skills. Remember, behavior can be extremely challenging in children that have had opioid exposures. You may need to give the parents some guidance on patience as well as being firm with their boundaries and their discipline expectations and consequences. These children often respond to first then language. So for example, first we're going to do our coloring and then you get your treat. They also respond to being told and not being asked. So instead of saying, do you want to take a bath? You say, it's time to take your bath. As a reminder, children with an NAS or NOWS diagnosis do qualify for early intervention, so please refer them quickly. And direct your families to other local resources, including developmental specialists. And remember, any child that has had opioid exposures is at risk for developmental differences and delays, but many children don't have any issues at all. This information is just to inform you of what you should be monitoring for. Thanks for spending time with me today. I hope this information has been helpful.
Hi, my name is Jill Rigsby. I'm the Director of Early Intervention Programming for Tennessee's Early Intervention System. And today I'd like to talk to you about services that will help support opioid-exposed newborns in your care. Tennessee's Early Intervention System, TEIS for short, is a voluntary educational program for families with children aged birth to 3 with disabilities or developmental delays. TEIS provides services as outlined in the Individuals with Disabilities Education Act, or IDEA. TEIS is a program of the Tennessee Department of Education, Division of Tennessee Early Intervention. First, I would like to talk to you about the approach of TEIS to service delivery. TEIS links families with services and supports to help them work with their child who has a disability and/or developmental delay. The focus of the service is to support families as they work with their children in daily routines and activities. The referral to a TEIS office is based upon the child's address. TEIS has 9 point-of-entry offices across the state, 3 in each grand region. In the West Tennessee region, we have offices in Martin, Jackson, and Memphis. In the Middle Tennessee region, our offices are in Cookeville, Nashville, and Murfreesboro. In the East Tennessee region, the offices are in Johnson City, Knoxville, and Chattanooga. So how can you make a referral? You can make a referral by calling the point of entry district office that provides services for the child's county of residence. You can call the TEIS referral line at 1-800-852-7157, or you can make an online referral via the TEIS website. 2018-19 referral source data shows that 51% of referrals to TEIS come from the medical community. The strong relationship between TEIS and the medical community is vital to the continued support of newborns and their families in Tennessee. When making a referral, this is the information that is needed by TEIS. Child's last name, parents or guardian name, parents or guardian contact information, child's date of birth, reason or reasons for the referral, and the referral source. An acknowledgement of referral is sent to all referral sources once it has been entered into the data system. If additional information is needed on the status of the referral, please note this within the referral. This will help to ensure that a release is obtained from the parent or guardian in order to communicate referral outcome information. What happens after the referral to TEIS? A 45-day timeline to determine eligibility and to write the plan for services begins. A letter is mailed to the family with a brochure providing questions and answer information to the family. An evaluator will call the family within 5 working days to schedule intake and an evaluation appointment. At initial appointment, the parent or guardian must give permission and sign release of information forms for medical records. The child must be present to conduct the evaluation. Here's what the parent or guardian can expect during the intake evaluation appointment. The evaluation appointment takes approximately 2 hours. Parents or guardians' rights are explained and questions are answered. Consent for evaluation is obtained and releases are signed for medical records. A developmental evaluation, vision, and hearing checklists are completed. The evaluator will share results of evaluation with family before leaving the home, but eligibility cannot be determined until medical records are reviewed. Medical records must be less than 6 months old and show a review of systems. The record can be either from a sick or a well child visit, and any additional medical records demonstrating a TEIS qualifying diagnosis should also be sent, regardless of the age of records. To be eligible for TEIS, children must demonstrate one or more of the following criteria. Diagnosis of one or more specific conditions likely to result in a developmental delay, as listed on the TEIS website. Neonatal abstinence syndrome, or NAS, neonatal opioid withdrawal syndrome, NOWS, is a diagnosis that falls into this category. An ICD-10 diagnosis code is required for all diagnosed conditions used for eligibility determination. Or a 25% delay in 2 developmental areas. Those developmental areas include motor, communication, cognition, social, and adaptive, or a 40% delay in 1 developmental area. Eligibility is determined through multidisciplinary approach, including a review of medical records containing a review of systems. When a child is eligible, the Individualized Family Service Plan, or IFSP, is developed. This plan identifies supports and services to address family priorities. It supports the child's successful participation in daily activities. It includes individual outcomes or goals for each child that are functional in everyday routines and that are measurable. The IFSP is reviewed by the team of service providers, including the parent, at a minimum of every 6 months. Once the IFSP is written, the team will determine the services to support the goals. Basic services outlined in IDEA include screening, service coordination, evaluation, assessment, developmental therapy, family services, nutrition, physical therapy, occupational therapy, communication development, vision, hearing services, assistive technology, and transportation. Services are provided by multiple agencies linked to TEIS. The type and amount of services to be provided for the child and family are described in the IFSP. The IFSP addresses child needs and the family resources, priorities and concerns related to identified developmental needs of the child. One big concern for parents might be the cost of these services. It is the right of every infant and toddler to receive an eligibility evaluation and service coordination at no cost. When a service has a cost, TEIS encourages families to allow access to their private and/or public insurance benefits. TEIS provides services for children birth to 3. For families who have children over the age of 3, here are some options available. Children ages 3 to 5 with disabilities or delays are covered under the Individuals with Disabilities Education Act, or IDEA, Part B, Section 619. School-aged children with disabilities or delays are covered under IDEA, Part B, Section 611. All IDEA programs in Tennessee are administered through the Department of Education's Division of Special Populations and Student Support. Children over age 3 with confirmed disabilities or delays receive an Individualized Education Plan, or an IEP, through the school system. To make a referral for a child over age 3, contact the Special Education, SPED, Director at the local education agency or school district where the child lives. How can you be a champion for TEIS? Educate families on what TEIS is. Refer to TEIS brochures and the TEIS website. Encourage families to stay in the TEIS program. Build a relationship with your local TEIS office. Always make the referral directly to the TEIS office, just like you would a medical referral. And educate yourself on the TEIS eligibility diagnosis list. The TEIS eligibility diagnosis list is updated periodically with the date of last revision noted on the website. We hope this information has been helpful. For more information or to make a referral, please contact your local point of entry district office or visit the TEIS website.